Ma'am, Justin, we'll start. We'll go ahead, madam. Meanwhile, the participants will join.
No issues. No
Okay.
issues.
Sir,
How many
Kurmana, sir?
postgraduates are there?
Sir, join అవుతున్నారు మేడం.
Okay.
4-5
Let them,
colleges
whoever
ఉన్నాయి.
is, let them be very active.
ఈ లోపల మనం
Hardly 15, I believe.
Okay. No, sir. No issues, sir. We'll start.
So good evening, everyone. On behalf of ISA Visakhapatnam City Branch, I extend a warm welcome to all the postgraduates, DNB residents, and young anesthesiologists attending this session 2 of postgraduate orientation and discussion series, an initiative aimed at providing focused and interactive academic platform. So before starting the session, let us have a praise song.
सरस्वती नमस्तुभ्यं वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा पद्मपत्रविशालाक्षी पद्मकेसरवर्णिनी नित्यं पद्मालयां देवी सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा.
May I now request the President of City Branch, Dr. Anuradha Madam, to give her introductory remarks.
Respected esteemed faculty, Dr. Madhavi Julakanti ma'am, and moderator Dr. KL Subramanyam sir, and Kalipatti Kurmanath sir, and Dr. Lakshmi Rani ma'am, and Dr. Sri Lakshmi ma'am, and Padma Amar Vishal ma'am, and Dr. Madhavi Julakanti ma'am, and dear colleagues and students, a very good evening to all. Our online lecture series will continue to bring in experts from across India and the world, allowing every member, regardless of schedule or location, to participate and stay updated with the evolving practitioners. As we step into this new term, our focus will be on strengthening both online and offline academic engagement. Together with the support of our seniors, mentors, and the enthusiasm of every member of our branch. Thank you all for your trust and support. Thank you.
So today's academic session includes two very important topics. The first topic is ABG interpretation, and the second one is anesthetic considerations in a child with hydrocephalus, posted for VP Shunt. So at this juncture, it is my privilege to introduce my teacher, Dr. Madhavi ma'am, as the guest speaker for today's session. Madhavi madam is a dedicated academician and an inspiring teacher. She will be guiding us through ABG interpretation. The second topic is an important case discussion on anesthetic considerations of a child with hydrocephalus posted for VP Shunt that would be done by the postgraduates of Andhra Medical College. So I'm confident that today's session will be enriching and beneficial to all the participants. I wish everyone a productive learning experience. So let me start today's session by introducing the moderators for the first session. Dr. KL Subramanian sir.
Good evening, sir.
Good evening, sir. Professor and Superintendent of Government Super Specialty Hospital, Anantapur, Dr. Kallepalli Kurmanath sir, Professor Gayatri Vidya Parishad Medical College, Dr. Lakshmi Rani Tekalpati, HOD Critical Care Hospitals. Over to the moderators. to continue the proceedings.
Good evening, sir. This is
Good evening, all moderators. Good evening, sir. Dr.
Yeah.
Anuradha.
Madam. Good evening, madam.
Good evening.
Good evening, all of you, all the persons and eminent persons on the board. I am Dr. K.L. Subramaniam from Anantapur. So today we have really a very good topic on ABG. The first topic is ABG because this is a very dry topic and especially useful for the postgraduates, practicing anesthesiologists and also faculty. This topic actually is aptly selected by the ISA Vizag branch. First of all, I would like to congratulate and thank the ISA Vizag branch for holding a series of webinars. So many webinars they have conducted and which were very useful for the postgraduates and the practicing anesthesiologists. And this ABG, as all of us know, because it's a very dry subject, as aptly selected by the ISA Vizag, we have a very good speaker, Dr. Madhavi Madam. So I think she will do justice for the today's topic. And I think it will be very much useful for the postgraduates because following this topic, ABG will be very useful. And not only following the topic, but also we have to practice it daily. We have to go on looking at the ECG and correlate clinically. Then only one can master the ABG. Thank you, Madam. Dr. Madhavi Madam. Dr. Madhavi Julakanti, she is a professor from Mahbub Nagar, Government Medical College, Telangana, and she is also a faculty for many state and journal conferences. And she has many publications in the national and international journals. And she is also a team member for organ procurement of brain dead donors and also a team member for liver and renal transplant surgeries in the Usmania General Hospital. And she is a faculty for GRACE under World Federation Society of Anesthesiologists, and she is trained in POCUS program. Thank you, Madhavi Madam, for sharing today's your valuable experiences on today's topic of ABG.
So thank you very much. Thank you all the moderator, ISA Visakhapatnam State Branch, especially Praveen, my student, and now the teacher for many students. I'm very happy and privileged to give a academic program of ABG. Everyone would say that it is very dry, but we'll make it better. So it is always that everyone during postgraduate exams or every time, every day, everyone nowadays is passionate, sir, to take the ABG if it is needed or not needed. So I'll start my today's ABG lecture so that we'll see that from day to bite, how do you make it.
Would like to congratulate Dr. Anuradha and Dr. Praveen for starting this type of PODS program, which is very much useful to all the postgraduates. And of course, as Madam said, Julakanti Madhavi Madam said, it is very useful not only for postgraduates and anesthesiology, is also useful for the physicians, nephrologists, cardiologists, almost all the medical fraternity. Kindly start, Madam.
Sir, my PPT is visible?
Yes, Madam, visible.
Okay, sir. Thank you. Sir, as we all know that the life of anesthesiologist evolves and revolves with A, B, C, D only. Whether you start off CPR, airway, breathing, circulation, drugs, everything. Like that, if you start regional anesthesia, it is alpha, beta, C, the neurons. And if you take ABG, it will start from ABG, is like acid-based disorders. So day-to-day practice without ABG, there is no one is making diagnosis. So how it started, the history. So to remember who made easy ABG to read for every physician or critical specialist or anesthesiologist, we should remember the people who started it. Especially before 1831, that O'Shaughnessy, what he had identified is something was losing in the cholera patients, that it was carbonate soda. This was the fundamental disturbance that he found it. So patients who are having diarrhea, they were going into shock. So the crystalloid therapy started with him. In the late 19th century, Arrhenius, who has described that the ionization, so what he defined is acid is as a moiety that delivers the hydrogen ion into aqueous solution. Today's most of the class will be hydrogen ion, PO2, PCO2 and bicarbonate only. So he started this. In 1909, that Henderson and Hesselbach, who had made the exactly equation where today we are most of the people starting with the Henderson-Hesselbach, which is really a very dry equation. But how to make it easy, we'll learn today. And followed by this Peter Stewart, who is a Canadian physician who had done, if you read so many books that they'll say that it is because of strong ions. What are the strong ions? He has made it as irrelevant to the electrophysiological approach. There are so many approaches, but we'll follow the basic and Stewart approach together so that it will make easy. So before starting, I told that what is ABG. So acid-base disorders never start only with hydrogen ion or bicarbonate. They'll start with the basic physiological process. What is that? Alveolar ventilation. In day-to-day practice of any anesthesiologist's critical care, ventilation is very important because the portion of total ventilation that parts in gas exchange with pulmonary blood. Why PaCO2 is the best index for alveolar ventilation? So whatever, every day you know that the metabolism of carbohydrates or fat, whatever happens, it should make a volatile largest acid, which is carbon dioxide. Every day 24,000 of milliequivalents per day it is produced and eliminated through the ventilation and through the other processes. So that's why if you check the PaCO2 depends on only one parameter. If you see what is according to us that tidal volume and respiratory rate, which is minute ventilation, which is really a marker and parameter, which is PaCO2 depends on only those two. That's why PaCO2, for example, we all are sitting here. You cannot predict what is your PaCO2 or what my PaCO2. It is only can be predicted. You have two monitors, whether it is in the operation theater, it is monitor where the EtCO2 is showing that it is some PaCO2 you can monitor or measure, or through ABG only the PaCO2 can be measured. Other than no other parameter or monitor will give you the EtCO2. Likewise, the ventilation followed by oxygenation. So if you take any ABG, you check that pH, PaO2 and PaCO2. Only these three parameters are measured by any ABG machine. Whether it is starting or till today, how much ever advancement is there in the ABG machine, you remember that these are only the measured parameters. So that's why PaO2, which provides a adequate delivery of oxygen tissues. For example, we are sitting all in the rooms. I'm giving you people lecture, you are listening. What is your PaO2? PaO2 is 80 to 100 with FiO2 at 0.21. You should be always able to remember that PaO2 means FiO2 you should know. Then only you can tell that the PaO2 is 80 to 100. For example, any patient who is with the nasal prawns or NRBM or any ventilator, if you know that the FiO2, you can exactly tell that the PaO2 is 80 to 100 mmHg only. So the PaO2 and FiO2 ratio, for example, if it is 100 by 0.21, that means 400 to 500. That is a good PaO2 FiO2 ratio. Mostly a patient which is in ARDS will know that the 400 to 500 is the normal marker. If it is less than 200, that means the shunt is more than 20%. So when is low PaO2? For low PaO2, we have only two problems. That is, for example, FiO2 is low or alveolo-capillary membrane is blocked. How will it get blocked? Pneumonia, pulmonary edema. Pneumonia is pus, or some water. Pulmonary edema, some water. Likewise, if there are two problems, there are only two solutions for this. So, what is the solution? Whenever FiO2 is low, if you are not in the, you are in the dark room where there is no room air of even 21, or if you are going high altitude, if FiO2 is the less also, so that time the two things, the increase FiO2 and alveolo-capillary membrane, whether it may be pneumonia, whether it may be fibrosis, whatever, what do? Most of the times we have to apply PEEP to increase the oxygenation to the tissues. So these are the two basic parameters which are the basic physiological processes if before going into acid-base disorders. So now the acid-base balance. What do we see in the acid base? Most of them hydrogen ion. The way hydroelectrostation, which gives our power and electricity, the same thing. The hydrogen ion is the active ion. Whenever there is alteration in the hydrogen ion, patient will have a acid-base balance. So likewise, in the human body, most of the times we all know that it is nothing but extracellular fluid or intracellular fluid partition, which is made up of only hydrogen. So that's why hydrogen activity measured is as pH. What is P? Nothing but it is a mathematical notion. Most of our tissues, for example, if you take ECF or ICF or any plasma, you take whatever it is, the hydrogen ion is very low concentrations. So the power of hydrogen is pH. So if we take as calculation, 1 liter of ECF is 55 moles of water, but only 40 nanomoles of active hydrogen. That means, for example, how do we calculate, measure sodium? Sodium is 140. Likewise, hydrogen also 140 means 140 nanomoles is active in the plasma or extracellular fluid anyway. So most of the times we measure extracellular fluid volume only. That's why what is happening in the intracellular fluid, it's very difficult to measure. That's why whatever we take the ABG every day, it is not the exact ABG. We don't find exact ABG. So you tell me all that what is the normal pH? It is 7.4 or 6.8? Any postgraduate? Any postgraduate? Praveen, please check.
Any postgraduate, please answer the question.
Is it 7.4 or 6.8? Why did I opt 2? Praveen, please check. What are the writing? It is 7.4.
PGs can answer in the chat box, ma'am.
Yes.
Chat box.
Please chat box. Praveen, check.
Okay, ma'am. Okay.
What did they write?
Nobody, one person wrote 7.4.
Okay.
Chaitanya Madhavi.
Okay. Then what is 6.8? Why did I mention it is 7.4 or 6.8? Anyone? Praveen, will you give the price? Or the moderator, sirs, will you give the price? Okay. See, 7.4 is extracellular pH. We take most of the time extracellular. Then what is 6.8? It is the intracellular pH. So that's why I asked you people to know that not only 7.4, you should know the intracellular pH also. So now we'll go to what is exactly the what is a normal pH. It is always calculated that 7.35 to 7.45. So that's why I took as 7.4. pH is always, see, you all see that it's very difficult to remember that whenever we look at, I have told you that Henderson-Hasselbalch equation, it is really difficult to remember. But if we make it easy way, so what is the ratio between nothing but bicarbonate and carbon dioxide? Okay, so we'll learn in future that what is exactly the bicarbonate ratio and CO2 ratio, how it will change the pH. So before going into acid-base balance, I want you all to know that what is OSIS, what is anemia. For example, acidosis, what is acidosis and what is acidemia. So always, for example, our body, what it does, it is always try to neutralize, whether it is metabolic alkalosis or acidosis, or whether it is respiratory. So it will try to always bring it to neutral way. So if the acidosis is the process, what is exactly happening? That is a process, whether it is acid or alkali. Okay, and emia is the state, that is the net product. For example, if any metabolic acidosis is happening, our body will try to compensate to bring the pH back to the 7.4. So the next is, I want you all to remember the normal values. For example, whenever we go to any shopping, for example, girls mostly nowadays, they go to Zudio, they'll go to Bata to buy something. There they'll give the normal prices to encourage you people that it is 999 or 1999, like that. To remember easily, I made it easy that the pH 7.35 to 7.45 and it is 7.4. You remember, you see that I made it as force everywhere, so that in future, if you want to calculate ABG, if you remember that all the force, PO2, okay, leave it. PCO2, 35 to 45 mmHg, I made it as 40 to remember. Like that, bicarbonate is 24. Base excess is, it is just the concept. Sodium 140, potassium 4, and chloride 104. So all fours to remember, easy to calculate the ABG. So remember this. So what is the first step? So there are 1, 2, 3, 4, 5 to 7 steps. For example, the first step, whenever you look at pH, whenever you see any ABG, first you look at pH, whether it is below 7.4 or it is above 7.4. If it is less than 7.4, you make it as it is acidosis. Okay, check the pH. Followed by the second step, you check that whether the primary disturbance is respiratory or metabolic. Remember only two, the respiratory, CO2, always the red force in our body. The metabolic component, bicarbonate, is always blue forces in our body. Likewise, the first step, whether look at pH, check that it is low or high. If it is low, acidosis. Why? Because I am telling the respiratory acidosis to remember first look at CO2, because whenever we go for any compensatory mechanism, the respiratory thing will do the compensation within minutes, seconds to minutes. And if it is metabolic, it will take hours to days. That's why you remember always that look at respiratory system. For example, you have seen the pH, followed by you check PCO2. Remember that whether it is low or high, and decide whether it is acidosis. If it is high PCO2, the respiratory acidosis. If it low PCO2, that respiratory alkalosis. If it is low bicarbonate, metabolic acidosis, and it is high bicarbonate, it is metabolic alkalosis. So these are the two steps. Afterwards, I want to give you all some. If please, I want the postgraduates to participate actively. That I have told you that the first step is to look at pH. Now I have given you the 2 to 3 example. What is the pH in the first question? Example. Anybody?
Vignesh, cheppu.
Vignesh, please. Vignesh, you are a postgraduate? Vignesh. Please. You have to participate actively. Otherwise, we cannot make it wet.
7.3.
Huh? pH is what?
7.3.
7.3. That means, what is the first step? It is acidic or alkalic?
Acidic.
Acidic. What happens to PCO2? I told you that to look at the PCO2.
It's increased, ma'am.
Increase. So what happened to the respiratory system?
Respiratory acidosis.
Respiratory acidosis. So what is the bicarbonate here?
26, ma'am.
Okay. Now I told you that there are two forces only. Okay. The red force is CO2 and the metabolic is. So what is here it doing? So what is, if you have taken only 2 steps, what is this condition called?
Respiratory acidosis.
Respiratory acidosis. Okay, good. So followed by, I'll give you one example. in the second scenario where the pH is 7.5, PCO2 is 28 and bicarbonate is 24. A young lady who is very anxious, she's hyperventilating, came to casualty. So looking at this ABG, what will you say that what is the primary thing? Any other person?
Yeah.
Any other postgrad? Or Vignesh, you can tell. Tell me.
Respiratory alkalosis.
Okay, how will you say that it's respiratory alkalosis?
pH is more than 7.4 and
Oh.
PCO2 is less than 40.
Less than 40.
Yes,
So
ma'am.
what is she doing? What is she doing?
Hyperventilating.
Hyperventilating. That means
So CO2
respiratory.
volume.
Yeah. Without you are knowing only PCO2 with the ABG. So she is eliminating the carbon dioxide. So the bicarbonate is normal or abnormal?
Normal.
Normal. So it is the primary respiratory alkalosis. Good. So I am taking only the first step and the second step. What is the third scenario?
Acidosis, ma'am.
Yeah. pH is low.
Yes, ma'am.
pH is low.
PCO2 is also low, ma'am.
Yeah. And
bicarbonate is also low. Ma'am,
Low.
this is metabolic alcohol acidosis, ma'am.
so here the which component is decreased more?
Bicarbonate.
Bicarbonate. That means it is a metabolic. Okay. The next one.
Ma'am, pH is if this is alkalosis, pH is more than 7.4.
Okay.
And PCO2 is in normal range. Bicarbonates increase, ma'am. This is metabolic alkalosis.
Yeah. So if you go back and see the Henderson-Hasselbalch equation, what it will show, the pH is ratio between bicarbonate and CO2. So what is here? It's happening in all the four situations. What is it happening? pH is whenever pH is increasing, the bicarbonate is decreasing, whether it is and vice versa. Okay. So these are the two steps. If I go back, the first step is pH low, acidosis, alkalosis. And the second step is we have known that the primary disturbance is respiratory or metabolic. Okay. Okay. Followed by the compensatory mechanism. Before going to the third and fourth step, you have to remember only 7 steps if you look at ABG, though we have taken the 2 steps. So what are the compensatory mechanisms in our body? So most of the times the regulation of pH depends upon the buffer systems. We all know that buffer systems, ventilatory response and renal response are important for compensatory mechanisms of our body. So what are the buffer systems which will produce local, immediate or incomplete response? So we have so many. Means most of the people, they say, for example, if you take the delta ratio, they'll tell that it is only bicarbonate. It is not like that. That bicarbonate and carbonic acid, which are in the plasma and EC, extracellular, intracellular and bone, which are they respond immediately but incompletely. So likewise, not only bicarbonate, if you look at in severe anemia, what happens? So it is also the acid-base balance will regulate and compensate. So hemoglobin is also very good compensatory mechanism. Likewise, other proteins in ICF are very important. Not only bicarbonate, hemoglobin and other proteins, phosphate in intracellular and extracellular fluid, which is in the bone also, very important buffer system, but it is only incomplete compensatory mechanism. If we take ventilatory response, for example, we were telling that of any lady who is anxious. So to compensate the hyperventilation, what she is doing, the compensatory mechanism, which is ventilatory response, which is slower but incomplete. Most important mechanism here is the acid removal, which is the carbonic acid removal. Metabolic acidosis always imposes a significant burden over the compensatory mechanisms. Likewise, remember that the renal response, which is very slow, it may happen in hours and days. But how it compensates that it will always try to conserve bicarbonate in the primary tubules. So excretion of hydrogen ions, plasma bicarbonate always freely filtered at the glomerulus and reabsorbs to maintain normal plasma bicarbonate at 25 milliequivalent per liter and plasma pH also. So the response is very slow, but it always compensates nearly complete pH, nearly, but not completely. But it's not like the buffer systems, it's not like the ventilator response, that renal response is slow, but it is nearly complete pH correction in the body. And remember that overcompensation in our body never occurs. So next is the respiratory acidosis, step 3. So I am taking the respiratory acidosis step because, hello?
Dr.
Anything?
Madhavi, it's
Yes.
Dr. Lakshmi here.
Yes.
Yeah,
ma'am.
so far, a lot of students are there. So far, you've said about 2 steps. Can
Yes.
I simplify and summarize them about the first
Yes,
2?
ma'am. Yes, ma'am. Please do
Then
it.
go
Please do
in
it, ma'am.
stepwise.
Please do it.
Yeah. Hi, all PGs and delegates who are attending. First, I would thank ISA Vizag branch for having me on this platform. And Dr. Madhavi is giving very good talk on ABGs, and we did see first step and second step so far. And the first step is you have seen whether it is acidemia or alkalemia, depending on whether it is less than 7.35 acidemia and more than 7.45 alkalemia. And then the second step is primary disorder, whether it is metabolic or respiratory. So how do we know which one is primary? Sometimes we get confused. We both are abnormal, but which one is the primary abnormality we have to see. So for that, I can give you one tip. When we see pH, see if it is acid. For example, if it's acidemia, you check PCO2 and bicarb. So if the PCO2 bicarb, one of them, whichever is going down, pH and the disorder both going downwards, is, you can think it's metabolic disorder. For example, your bicarb going below 24, below 22, you'll say acidemia. If it is less than 7.35 and your bicarb also going down, so you can say it's a metabolic. So if it is metabolic, both pH and the disorder will be in the same direction. If the bicarb is going
It's Rome, ROME, Rome.
No, acidosis, metabolic acidosis, or if it is metabolic, if it is alkalosis, then metabolic alkalosis, both bicarb and both pH, both will go up. So in metabolic disorder, both will be in the same direction. And if it is respiratory, for example, if as ma'am said, if somebody is hyperventilating and you're washing out all your CO2 is going down, right? So when your CO2 going down, it's becoming respiratory alkalosis. So, and your pH is going up. So if the disorder and the pH in opposite directions, it's usually the respiratory is the primary disorder. So in opposite directions, if it is going, then you can think of respiratory problem, primary. If it is going in the same direction, you can think of, you can say it's a metabolic disorder. So that way you can say primary disorder is what? Then you have to go for compensation, whether it's compensated for the primary disorder or not. So the step 3 ma'am is going through, that's regarding compensation. Thank you.
Sorry to interrupt, madam, Dr. Rani, madam. First, we'll let Dr. Madhavi, madam, complete her talk. Then we can moderate the things, madam.
Yeah, that's correct, sir. But for this, I thought stepwise, if they can remember, they can do at the end, maybe ma'am will give full ABG scenarios or numbers. So it's easy for them from the beginning stepwise how to go. That's why I just
Okay.
It's okay, ma'am. No
No
problem.
issue,
No,
madam.
ma'am.
No issue.
It will be
Thank you, madam.
mostly interactive only. No
Yeah,
issues. Whoever will have tips will go further. No problem.
sure. Thank you.
Okay.
Thank you, madam.
Okay. So the next step will be whether the respiratory or metabolic we have learned. So respiratory acidosis, whether it is acute or chronic. So acute or chronic, for example, any patient pneumonia or bronchial asthma exacerbation who will have and who will retain the CO2 forces more. That means CO2 is increasing. So for that, always the rule of thumb is that our body will start compensating. So how the compensation will happen? For example, if PCO2 is increased from 40 to 50, that means in acute conditions, if PCO2 is raised, that the expected pH, remember this formula that 0.08 of pH will be decreased. So in chronic conditions, like for example, restrictive lung disease or somewhere, the pH, PCO2, if it is increased in chronic conditions, the pH will reduce 0.03 only. These are the mathematical equations, the expected. This is the change, what is happening in the body to normalize, to bring the pH back. That is the thing. So extent of the, not the renal, not the extent of the metabolic compensation in the step 4. You all remember that 1 for 10, 4 for 10, 2 for 10, 5 for 10. Now I'll give you the examples. For example, if PaCO2 is raised to 80, for example. So it is acute respiratory acidosis. The bicarbonate from 24 to how much it will change? Anybody among PGs? PaCO2 have increased acutely to 80. A person who is ganja consumer, sedative, is sleeping, hypoventilating, the PaCO2 level is not breathing properly, ventilating properly. So his PaCO2 is raised to 80. So how will the bicarbonate, according to the formula, is 1 for 10. How much bicarbonate will increase? Praveen, anybody answer?
Shivaji said 28, ma'am.
28. Nice. Now you have understood that the PaCO2 in acute conditions, every 10 PaCO2 increase, the bicarbonate increase per 1. That means 40 of PaCO2 increase, 28 bicarbonate. Next, chronic respiratory acidosis. Any person who is having kyphoscoliosis, restrictive lung disease, or COPD, prolonged respiratory acidosis. The PaCO2 is increased. He is habituated. Remember that he is habituated that his PaCO2 is increases from 60, 70 or 80. So how much of bicarbonate will increase in chronic respiratory acidosis? From 24, how much? Praveen, anybody answer?
No, ma'am.
Easy. Remember, the first
30,
person said that
32.
32. How? 80. Is it 32 or something else? 40 it has increased. No, every 10, how much
40.
it should increase? How much it should increase?
40.
40. Yes. So likewise, you always remember whenever you let get ABG there, the metabolic compensation in respiratory acidosis should be 1 for 10, 4 for 10 to bring the pH back. The body always try to bring the pH back only. It is the rule of thumb. And now if we go, any patient who has got trauma, very anxious, that the PaCO2 from 40, it has decreased to 20. So what will be the bicarbonate? I told that the 2 for 10. That means if PaCO2 is decreased from 40 to 20, so how much of bicarbonate should get decreased? Praveen, anybody?
Nobody answered.
Nobody answered. Let them answer. Let them answer.
20.
20. They should learn like that only. Okay. Good that. See, PaCO2 from 42. I'm giving you a very simple example. That 42, it has decreased to 20. That means 2 bicarbonate for every 10, it is decreased. That means 4 decrease. It is simple. In chronic respiratory alkalosis, for example, any patient has gone for high altitude or severe anemia. What happens to the the metabolic compensation? Again, here the PaCO2 decreased from 40 to 20 only. So what is the bicarbonate? How much it will decrease? It should get decreased. Every 10 decrease in PaCO2, the 5 bicarbonate should get decreased to normalize or neutralize the pH. How much it will come? Bicarbonate.
14.
14.
Somebody
Yes.
said.
Yes, correct. So you have understood that the 2 steps, 3rd step and 4th. So likewise, in acute respiratory acidosis, the bicarbonate will increase 1 for each 10 rise in CO2. Understood? The same thing I have told that the 4 bicarbonate in chronic respiratory acidosis. So these are the examples. Followed by we'll go. So I'm talking first about the only acidosis parameters. Followed by I'll give you people what will happen with the alkalosis part. So metabolic acidosis, which is the step of the 5. So we have learned 4. What is the acidic or alkalosis? Primary disturbance followed by the compensation. What is the compensation? pH, how much it should decrease? How much it is the bicarbonate will increase or decrease? So metabolic acidosis now. The pH is 7.32. Bicarbonate is 18. Madam was telling that the pH decrease, bicarbonate is decreased, the metabolic is coming down, both the sides. So PaCO2 also will decrease. So it is called partially compensated metabolic acidosis. For example, metabolic acidosis. When do we see? So you remember that this is the metabolic acidosis, which is very vulnerable for most of the postgraduates, clinicians who are working in critical care. It is very difficult to treat and understand the metabolic acidosis. So what, for example, if any person is going, that means bicarbonate, that means the blue force in our body is getting decreased. You remember that always, whenever the metabolic force is decreased, automatically the respiratory carbon dioxide also try to decrease and do compensation. It is never that something will come and add. So whenever something is decreasing, again the other thing also will decrease or increase to neutralize. So like that, in metabolic acidosis, for example, lactic acidosis, or any person who is in sepsis, most of the times we see old people coming with cellulitis and sepsis, metabolic something, otherwise some acid is joining in our body, hydrochloric acid. It's just for example. So it is joining. So acid is increasing, so bicarbonate is decreasing in nature. So whenever, but the compensatory mechanism, you remember that the Winter's formula. For example, what we learned, 1 for 10, 4 for 10, 2 for 10, like that. The same thing in the metabolic acidosis also. To remember for exam purpose or for regular practice purpose, the expected PCO2 should be the Winter's formula. For example, 1.5 times of bicarbonate. What is the bicarbonate above? Is 18. 18 into 1.5, how much? How much? Praveen, anybody?
27.
27 plus 8, how much?
35.
35. So whenever the bicarbonate is decreased, the pH is 7.3, the expected PCO2 here, the compensatory mechanism, whatever is happening, should be 35. But to remember every time is very difficult. That's why remember, there is one more formula to easily remember for practice purpose or for learning purpose. The PCO2 should be equal to 2 digits of pH. For example, when we calculated, it was 35. But most of the time what happens, the pH when is 7.32, the PCO2 nearly 32. To remember easily, that pH, if it is 7.25, the PCO2 is 25. If pH is 7, how much will be the PCO2? Any idea? Any idea? When pH is 7, what will be the PCO2? I told you people that the Winter's formula is expected PCO2. It should be 35, but it is 32. To easily remember that PCO2 should be equal to 2 digits of pH. So if it is pH is 7, what will be the PCO2? How much? How much? How did you? How much? So this formula will be there till pH of 7.15 only. This formula does not go beyond or below pH 7, because when any person will have pH of 7, the PCO2 patient may survive or may not survive. That's why this formula only till pH 7.15 or 25, that's it. So PCO2 less than 15 we never see in any clinical condition. And remember that in such conditions, whenever we have to ventilate, respirate, so our PaCO2, our body will try to maintain the PaCO2 minimum 15 to 20 mmHg only. Below that, this formula does not apply. Remember that. So we have learned the 5 steps. So what is the 6th step? If whenever you see that the metabolic acidosis, there are respiratory acidosis, metabolic acidosis, you see, whenever you see that you look at the compensation, followed by the 6th step is anion gap. When I was telling you people to remember the sodium, potassium, chloride, and major cations and anions and the bicarbonate, I told you people to remember the number, means 4. So sodium is 140, which is the major cation in our body. So the chloride 104 and bicarbonate is 24. You please calculate what is the major cation and what is the major anions. Sodium is 140. And now major anions are chloride and bicarbonate. I'm not taking as potassium. To easy remember, or nowadays so many formulas are there that if you want to really know that the anion gap, you take only sodium, which is the major cation, and you take the major anions, which are chloride and bicarbonate. How much the bicarbonate and chloride? Anybody? Praveen?
128.
128. So I've given already there that 140 minus 120 is 12 is the normal anion gap. So remember that whenever we look at metabolic acidosis only, we see whether it is anion gap, which is normal anion gap metabolic acidosis, or high anion gap metabolic acidosis. So look at always, see nowadays so many ABG machines which are showing even the electrolytes. If you don't have the electrolytes, you have to count with the electrolytes. The patient is having a metabolic acidosis, which is a normal anion gap, which is NAGMA, and which is high anion gap, which is HAGMA. NAGMA is not the film actress. Here, the normal anion gap metabolic acidosis is, which is the 12. Okay, to remember. So what are the conditions where we see? You see that hypokalemia, where GI losses. So where the bicarbonate, diarrhea mostly, renal losses of bicarbonate, which is proximal renal tubular acidosis. So in the hypokalemia, normokalemia, and hyperkalemia states, whenever there is renal tubular diseases, the pharmacologically ammonia chloride, there are so many conditions. You please go through the literature that normal anion gap metabolic acidosis, what are the conditions, and what are the high anion gap metabolic acidosis. Remember that there are so many mnemonic, that is cult ketosis, lactic acidosis, uremia, cult mud piles. Since UG periods, we are trying that. One more gold mark is there. So one more, the cat is there where carbon monoxide, aminoglycoside, theophylline. So remember that in the sixth step, you have to know whenever you look at metabolic acidosis that the gap is normal or not. See here, why? Because see, whenever we go back. Anion gap. So this one here, we check only normal anion gap or high anion gap. What are the other cations and other anions which are not measured? Anybody, please? Anybody, please? What are other things? Can we measure
Albumin, lactate.
Huh?
Albumin, lactate. Somebody
Yes.
wrote albumin, lactate.
Okay. Nice. And? And?
Proteins. Albumin chepparu.
Okay. Anybody? Phosphates, sulfates. Can we measure them?
There's no college.
Can we measure them? Can we measure them? So we cannot measure them. So that's why mostly we take to rule out the anion gaps, which is normal or high acid normal gaps. So which will be compensating in other areas. So we'll take these three parameters to easily remember. Remember always that only metabolic acidosis will have. So what about the base excess and base deficit? So metabolic component of acidosis or alkalosis is base excess. Normally, it is a theoretical part, not in the practical part. For example, if you look at ABG, if you see the base excess is +5, that means it is the component of alkali. If you see the -5, that means it is acidic component. So always remember that it is a metabolic component. So base deficit or excess for treatment purpose or for this purpose, it does not give anything. So always the base deficit and excess is always +2 or -2. That means it is 0 only. So the base deficit and excess is the amount of deviation of the standard bicarb from the normal. So I told you in the beginning only that the measured and calculated ones, only we see this base excess or base deficit, which does not have much practical importance. Likewise, you have to know that what is actual bicarbonate, what is the standard. Actual bicarbonate is the value which is the blood gas sample. For example, whenever you are seeing the whole blood, you are seeing the bicarbonate, that is called actual. When it is standardized means the corrected bicarbonate, that means the sample between is corrected to PaCO2 of 40 mmHg or room temperature. This also it does not have a proper clinical importance. Just to know about what is actual blood count, which is the whole blood sample, you are knowing the bicarbonate, and when it is changing or corrected at PaCO2 of 40 at room temperature of 37, it is called standard bicarbonate. So we have learned that the most of the places where the metabolic acidosis and respiratory acidosis, which is anion gap with the 7 steps. So followed by the respiratory alkalosis. Respiratory alkalosis, whenever I have told you people that whenever patient hyperventilates with CNS simulation, hypoxemia or drugs or miscellaneous sepsis, pregnancy or physiological responses, that you see the respiratory alkalosis. So in the respiratory alkalosis also, for example, 2 for 10. For example, 10 of what is decreasing in respiratory alkalosis? If pH is 7.5, what is happening? Anybody?
PCO2.
What happens to PCO2? Increasing or decreasing?
Decreases.
So what happens? So what is happening? Acute respiratory alkalosis. when I was speaking about respiratory acidosis, I told you people that whenever the PCO2 decreases to 20, that the bicarbonate should decrease to how much? 2 for 10. 2 for 10. Same that in chronic respiratory, high altitude systems, everywhere, PaCO2, for example, 28, that the bicarbonate should decrease from 24 to 14. Okay? Yes. So metabolic alkalosis. So, for example, in the metabolic, these are all the causes. Whenever metabolic alkalosis is there, that loss of hydrogen ions. Whenever patient is having too much of vomitings, patient has taken diuretics or increased reabsorption of bicarbonate. For example, in hypokalemia or high PCO2, or we are using any increased mineralocorticoids. So the last one is whenever 2 for 10 PaCO2, whenever it is decreasing by 10 or 20, the bicarbonate also will decrease. Likewise, expected PCO2 in metabolic alkalosis is 1.5 into bicarbonate plus or 8. So the same thing that was winter formula I told you, expected PCO2 also, this will change. Okay. Now, do we treat metabolic acidosis? Do we treat metabolic acidosis? Anybody? If we treat with what? Who told that it is soda bicarb? Who told that it is soda bicarb?
Yeah,
Okay.
तो एक ही रोटी बनाओ महाराज.
Okay, Praveen.
Right, and he did over that I feel that she needs to be careful.
Praveen,
Zohra.
mute them, please.
Ma'am, you have to unmute, Madhavi. Ma'am, you have to unmute. Ma'am, you have to unmute.
Madam, you have to unmute yourself, madam. It is not audible.
Dr. Madhavi, please unmute.
Ma'am, you have to unmute.
Now?
Yeah, now audible, ma'am.
Yeah. No.
Okay, sir. Now my PPT is visible?
Yeah, visible.
Yeah. See, most of the postgraduates, whenever they'll see the metabolic acidosis, whenever they see bicarbonate is 18, 15, they'll start giving soda bicarbonate, which is very wrong. So whenever patient with metabolic acidosis, what are the reasons? Maybe patient is in shock, treat with inotropes. Patient with diabetic ketoacidosis, please treat with fluids and insulin. Patient with sepsis, treat with fluids and antibiotics. When to give really a soda bicarb? When you all know that whenever we give soda bicarbonate, how much we start? 0.5 to 1 milliequivalent per kg will start. So if you give the soda bicarbonate, so how much of carbon dioxide will be released? Anyone has any idea? Anyone has any idea? There is liters, if you give like that, liters of carbon dioxide, 180 ml per every 0.5 milli equivalent of your soda bicarbonate is released. So that much load we cannot tolerate. To compensate that much of CO2 production with soda bicarbonate, you have to hyperventilate, or you have to increase your ventilation for so many times that patient won't have that much energy to hyperventilate, or you cannot hyperventilate so much that to eliminate the carbon dioxide. That's why please don't start soda bicarb. Only give soda bicarb whenever patient is having hyperkalemia, so that potassium will enter from extracellular to intracellular. Whenever there is sodium channel blocker overdoses like tricyclic antidepressants, salicylate poisoning whenever you want to make urine alkalinized, and whenever there is a normal anion gap metabolic acidosis in some condition, then only give please soda bicarbonate, otherwise don't give. Okay, treatment of respiratory acidosis. Remember all the postgraduates that we have only two things to be remembered. Whenever there is a improper oxygenation, use the FiO2 button and PEEP button. Whenever there is respiratory acidosis, use respiratory rate, tidal volume, try to ventilate minute ventilation properly. If patient is 60 kg into 100, 6 liter of minute ventilation. If you want to increase minute ventilation, if respiratory acidosis, you want to eliminate the PaCO2 from 40 to 60, you give mechanical minute ventilation increase by 1.5 times only. So you treat metabolic acidosis and respiratory acidosis in that manner. So now look at the ABG. The first ABG, when you remember that whenever we look at ABG, the right one and the left one, you see that always the entered data should be there. Always remember that FiO2, whether it is 30 or 40, 50, before you give the PaO2, the values. So that's why if patient FiO2 is 30 means, remember that the 5 times of partial pressure of oxygen will increase. So, remember always the measured, the data in the ABG analysis is pH, PCO2 and PO2. The bicarbonate which we are talking about is also a calculated data. The calculated data is the according to the equations only. That equations is Henderson-Hasselbalch equation, which always will produce by the ABG. So the left side data, you remember that recent, the right one is 2001, recent one is 2025. A patient with cellulitis who is in the ward, who is a normal person, looking at that ABG, can you tell that it is ABG or VBG? Anybody please? If you'll answer, we'll finish very fastly. Praveen, we'll finish. I'll finish within 5 minutes.
Yes.
Okay. Okay.
VBG. Somebody said VBG.
VBG. Okay. So that's why VBG. I want to tell you people that, see, this is the, always remember that the AA gradient also important to know, but the AA gradient sometimes you'll know in the ABG and sometimes you may not know in the ABG. So the AA gradient which will give or predict the degree of shunt. I told you whenever the PaO2 is 100, that means FiO2 is 2. The PaO2 FiO2 ratio is 400 to 500. If it is PaO2 FiO2 ratio is less than 200, that means the shunt is more than 20%. Likewise, the AA gradient also will show the degree of shunt. If AA gradient is normal is 5 to 10 mmHg, according to the Bohr's equation, every patient, every postgraduate from first year to last year, they should know the what is alveolar gas equation. Please learn that. If wide AA gradient, that means patient is having a parenchymal lung disease. A patient with AA gradient normal with low PaO2, that means the patient is hypoventilating. The normal AA gradient less than means age in years by 4 plus 4. These are the equations which are to be remembered and learned and read. Okay, so before finishing, I want to give you people some example that ABG versus what is VBG. So there is very less change according to so many studies that always For example, one of my technician will come and tell gratefully that, Madam, today I've done ABG. He doesn't know. If he pricks himself, he'll understand, but it is not our body. That does not mean that you prick so many times the artery. So now the era is VBG, that whenever in venous sample, if it is less than 50% of venous O2, then go for ABG. Otherwise, no need. You go through all the parameters that very less norm, VBG and ABG. There are so many studies that the PCO2 is very less change, and HCO3 or PCO3, so many are very less if you compare ABG, VBG. Now the era is VBG. Remember that. And the first question, I want to give some examples, the postgraduates, if they want, they can share. The pH is 7.3 PeCO2. You please calculate whether it is metabolic acidosis or respiratory acidosis with normal anion gap or abnormal anion gap. Shall I skip? Shall I skip? Skip. So I want anybody to please go through this normal ABG. Please. Anybody? The way we learned till now. Praveen, anybody answering?
Nobody replied, ma'am, so far.
Okay. Okay, we'll finish. Okay. Mostly no one is must be in prayer. Remember that. Remember, most of the postgraduate, I request you all to remember, to be remembered the entered data, measured values, what are the calculated data. The step one is whether it is acidosis or alkalosis, primary disturbance, acute chronic, what is the extent of renal compensation, metabolic compensation, respiratory compensation, and anion gap. Okay. Arise, awake, and stop not until the goal is reached. So you should all, everyone should know what is a normal ABG, what is abnormal ABG. Thank you all for patient listening. Thank you. Thank you, the Vizag team, for calling me and giving me the opportunity to talk about ABG. Really, it is, if you read and go through so much of practical knowledge, if you go, how much ever you learn the theory, you won't understand. If you go and practice, then only you'll reach. Thank you all.
Thank you, Dr. Madhavi, madam.
Thank
It
you,
was
sir.
really a wonderful presentation.
Thank you, sir.
Also, you have explained each and every aspect in detail.
Thank you, sir.
So you have given simple tips to remember, especially for the postgraduates, because those tips they can remember even at the time of examination also. Really, thank you for your presentation.
Thank you, sir.
Now I can say a single statement: ABG is made easy now.
Sir, thank you.
Thank you, ma'am. Other moderators can comment. Dr. Rani, ma'am.
Sir, it will be very, it will be very easy for postgraduate whenever they participate. So that's why I've taken so many recent ABGs, because time doesn't, one more class is there. That's why I stopped, but let them enjoy. Sir.
And also you have thrown some light on VBG also. That's
yes,
good.
Sir.
Yes.
That's right.
Thank you.
Very nice, madam. It is spoon feeding to the postgraduates.
Thank you, sir. Thank you, sir. Thank you.
Thank you, Dr. Madhavi, ma'am. Nice talk. Yeah, I mean, not only anesthesia PGs, many times they do duties in ICU. So definitely in ICU day-to-day practice, we do ABGs or VBGs. As you said, nowadays we are checking VBG. If it is too low, then you have to think about whether it's alveolar problem or FiO2 problem or whatever it is. So nicely explained. Thank you so much. So if please do that stepwise manner, I'm sure they do really well. And I mean, after that, after the primary one, sometimes very rarely PGs in exams, they end up getting the questions about mixed disorders. So that's an advanced thing. But basically for PGs, if they know primary disorder and compensation, that's good enough. Thank you so much.
Thank you. Thank you.
Sir, if there are no more questions. Thank you, all the moderators. And thank you, ma'am, for a wonderful topic discussion. So we'll be going on to the next topic for today. Anesthetic considerations in a child with hydrocephalus posted for VP Shunt. The examiners for this session are Dr. K. Srilakshmi ma'am, Professor and Head of the Department, Andhra Medical College. Dr. Padma Amar Vishal ma'am, Professor and Head of the Department, NRA Medical College. Dr. Madhavi Julakanti ma'am, Professor, Mehboob Nagar. So may I introduce the postgraduates for today's session, Dr. Sharmila and Dr. Fani Kumar from Andhra Medical College. They will be doing the presentation.
A very good evening to the respected Professor and Head of Department, Dr. K. Srilakshmi ma'am, Andhra Medical College, and to all my professors and faculty and all my dear postgraduates, colleagues. A very good evening to all. I am Dr. Fani Kumar and this is Dr. Shemla. Today we are going to present a case discussion, a child with hydrocephalus posted for VP Shunt procedure.
May I request Srilakshmi ma'am to give initial remarks.
Good evening, everyone. My seniors and dear postgraduates. Today's topic for case discussion is a short case, that is hydrocephalus. We will be doing, though the incidence of hydrocephalus is 1 in 1,000 births, but we will be doing so many cases per month. We will be nearly doing 4 to 6 cases. So that's the reason why we have selected this hydrocephalus case. And now I welcome Dr. Fani Kumar and Sharmila to present the case of hydrocephalus, 5 months old baby. Fani Kumar, present the case.
Padma ma'am, if you have any remarks.
Yeah. This is a very good, good evening all, and thank you for the opportunity to interact with all the postgraduates. And even this is a very good platform for our PGs to interact and to listen to all the eminent faculty. And it is very good initiative from the Visakhapatnam ISA branch. So I congratulate them to start this PG activity. So we will proceed with the case.
A very good evening, ma'am. Today we are going to discuss about the child with hydrocephalus, a case posted for the VP Shunt procedure. Now, my moderators are Dr. K. Srilakshmi ma'am, Professor and Head of the Department, Department of Anesthesia, Andhra Medical College. Case presentation. A 5-month-old male child, baby of Durga, resident of Anakapalli, belonging to low socioeconomic status, was brought to the hospital with a chief complaint of increase in size of the head since 1.5 months and fever since 8 days. History of present illness. History of increase in head size since 1.5 months, which is gradual and progressive to the present size. History of fever since 8 days, which is low grade and intermittent type, not associated with chills and rigors. No aggravating factors and temporarily relieved on medication. History of decreased activity since 1 week. History of projectile non-bilious vomiting since 2 days, 3 to 4 episodes per day. History of refusal of feeds since 2 days and excessive crying. No history of difficulty in micturition or passing stools. No history of cold, cough, or difficulty in breathing. No history of seizures or cyanotic spells. Past history. No history of similar complaints in the past. No history of convulsions or bronchial asthma or TB contact. No history of blood transfusions or surgeries in the past. No history of any drug allergies. Family history nil significant. Natal history. Antenatal history is uneventful. Baby is a single term LSCS male child with 3 kgs, cried immediately after birth, non-consanguineous marriage. Postnatal, no history of NICU admission. Immunization history, the baby is immunized as per the scheduled time with BCG, OPV, pentavalent, rota given. Developmental history is delayed. Gross motor, no neck holding, fine motor, no bidextrous reach, social, doesn't recognize the mother, language doesn't alert to sounds. Personal history, normal gastric colic reflex is present. Airway examination cannot be assessed as it is 5 months baby. Examination of the spine to rule out neural tube defects, no tuft of hair, no swellings of the spine, and no spinal deformity. Head examination, which includes inspection. Shape of the head is large head and asymmetrical. Skin is thin and shiny. Anterior fontanelle is wide, tense, and bulging. Cranial suture diastasis is present and scalp veins are dilated. Eye signs shows sunset sign is present and downward gaze is present. No lateral rectus palsy, no congenital cataract, no Lisch nodules, and bilateral pupillary reflexes are normal. On palpation, cranial sutures are separated. Movement of upper limbs and lower limbs are normal. Spine is normal. No spasticity is found. Percussion of the skull produces a cracky pot resonant note, McEwen sign. On auscultation, no bruit heard over the skull. Systemic examination includes central nervous system. The patient is drowsy. Sensory and cranial nerve examination could not be done. Gross motor examination, bulk and tone was normal on all 4 limbs. Respiratory system. Chest is normal on inspection, no chest retractions. Bilateral, equal air entry present, normal vesicular breath sounds are heard, and no added sounds. Cardiac vascular system, no precordial bulge, no scars or sinuses on chest wall. S1 and S2 heart sounds are heard, and no murmurs. GIT per abdomen, soft, no tenderness, no organomegaly. Probable diagnosis is a 5-month-old male child was brought to the hospital with enlarged head, which is progressive. It's a case of congenital non-communicating hydrocephalus due to aqueductal stenosis planned for ventriculoperitoneal shunt.
So what are the positive features? Why you
Positive features in this patient are low socioeconomic status, increased head circumference, fever, poor feeding, vomiting, excessive crying, delayed milestones. On examination, child is drowsy.
Okay. What is hydrocephalus?
Hydrocephalus is a condition caused by an imbalance in the production and absorption of CSF in the ventricular system. When production exceeds absorption, CSF accumulates, usually under pressure, producing dilatation of the ventricles.
So what is the normal head circumference or increased per month in a child?
When it is 0 to 3 months of age, head circumference is increased 2 centimeters per month. When it is 3 to 6 months of age, head circumference is increased by 1 centimeter per month. When it is 6 to 9 months, it is increased by 0.5 centimeters per month. When it is 9 to 12 months, it is increased by 0.5 centimeters per month. 1 to 3 years, it is increased by 0.25 centimeters per month. 4 to 6 years, it is increased by 1 centimeter per month.
So what is the circumference at present at 5 months now the baby is having?
60 centimeters.
Okay, very good. So what is hydrocephalus?
Hydrocephalus is a condition caused by an imbalance in the production and absorption of CSF in the ventricular system. When production exceeds absorption, CSF accumulates, usually under pressure, producing dilatation of the ventricles.
So what are the causes for hydrocephalus?
Hydrocephalus causes are communicating hydrocephalus causes are achondroplasia, craniofacial syndromes, other skull-based deformities. Acquired causes are subarachnoid or intraventricular hemorrhage, choroidal plexus papilloma or choroidal plexus carcinoma. Post-infectious causes. Most common is tuberculosis. It is the most common cause of hydrocephalus, infectious cause of hydrocephalus in India. Non-communicating hydrocephalus causes are aqueductal stenosis, vein of Galen aneurysm, gyri malformation, X-linked hydrocephalus, Dandy-Walker malformation. Acquired causes of non-communicating hydrocephalus are tumors, post-inflammatory adhesions, cerebellar hematomas, and infarcts.
So congenital are communicating and acquired are usually non-communicating.
Non-communicating.
So what is normal pressure hydrocephalus?
Normal pressure
So
hydrocephalus is normal pressure hydrocephalus is a chronic type of communicating hydrocephalus, ma'am. It is characterized by ventricular dilatation with normal CS of opening pressure on lumbar puncture. Presentation classically in the elderly patient, ma'am, due to impaired absorption at the arachnoid villi. Classical clinical triad of normal pressure hydrocephalus includes Hakim Adams triad, which includes gait disturbances, dementia, and urinary incontinence.
Okay, it is usually seen in elderly people.
Elderly
So,
people.
what are the signs and symptoms of hydrocephalus in your case? In 5 months old, in your case?
Yes.
Hydrocephalus clinical presentation depends upon the pathology, site of obstruction, speed of onset, and age of the patient, ma'am. When hydrocephalus presentation is slow, there will be seen large head, sunset eyes, irritability, headaches, poor feeding, delayed milestones, confusion, lethargy, weakness, unsteady gait, seizures, incontinence, cracked pot sign. When hydrocephalus presentation is acute, we'll see it will be presented as severe headache, vomiting, dehydration, unconsciousness, neurogenic pulmonary edema, brainstem herniation, cardiorespiratory arrest, and death also can occur. Signs
So,
of hydrocephalus: widening of the sutures and enlargement of the head circumference, cracked pot sign, which is nothing but McEwan's sign, papilla edema, which is which can be reverted after treatment, signs of increased ICPR, frontal palsy, dilated scalp veins, cranial nerve palsy, which includes 6th nerve palsy, 10th nerve palsy, 2nd nerve palsy, and 3rd nerve palsy, bradycardia, hypertension, changes in respiratory rate, depressed consciousness, and seizures. There are chances of pulmonary aspiration, syndromic features, signs related with tubercular meningitis, tumors, and hemorrhages.
So these will cause an increase in the CSF production, either decreased absorption or obstruction. So what is CSF then?
CSF is an ultrafiltrate of plasma that enters the basal side of the choroid epithelium by active metabolism. It is transferred into CSF and secreted at the apical or ventricular side of the epithelium. Most of the CSF is formed by choroidal plexus 80% and parenchyma 20%. CSF is produced at a rate of 0.5 ml per minute with around 150 to 200 ml produced and absorbed per day, and at any given time around 25%, that is 60 to 80 ml present in the ventricles. CSF transferred from the subarachnoid space into superior sagittal sinus through small granulations called arachnoid villi. Normal CSF pressure on lying down is 130 mm of water or 10 mm mercury. In vertical position, it is slightly elevated, 375 to 550 mm of water.
So it is dynamic. CSF
Dynamic.
is. What is the circulation of CSF? How
The circulation of
from the production to absorption?
CSF is generally produced at the choroid plexus of the lateral ventricles. From there, it reaches the third ventricle through the foramen of Monro, and from third ventricle to fourth ventricle through aqueduct of Sylvius. From fourth ventricle onwards, through the foramen of Megendi and foramen of Leschka on either side, it enters the subarachnoid space and it again reaches upwards and absorbed by the arachnoid villi.
What is the importance of CSF? What are the functions?
CSF has 3 important life-sustaining functions, ma'am. First, it is to keep the brain tissue buoyant by acting as cushion or as shock absorber. And second, it acts as a vehicle for delivering nutrients to the brain and removing waste from the metabolism. And it acts to flow between cranium and the spine and compensates for changes in the intracranial blood volume. And it maintains ionic homeostasis.
So what happens is CSF increases and causes an increased intracranial pressure. And what is ICP?
What is intracranial pressure is the pressure exerted by the cerebrospinal fluid inside the skull and on the brain tissue. ICP is dynamic in nature. It varies with posture, arterial blood pressure, venous blood pressure, respiratory cycles, and cough. Normal ICP pressures are 7 to 15 mm mercury in adults, 3 to 7 for young children, 1.5 to 6 mm mercury for term infants, and more than 20 mm mercury is diagnosed as raised ICP. ICP values over 20 to 25 are indicative of intracranial hypertension and focal ischemia.
So what are the signs and symptoms of raised intracranial pressure?
In infants, it presents as headache, diplopia, papilledema, vomiting, and decreased level of consciousness. Third and sixth nerve palsies, loss of upward gaze, which is nothing but the sun setting sign, signs of herniation, Cushing's triad, and pupillary changes.
Okay. What is Monroe-Kellow doctrine or hypothesis in case of cranium, which is a closed compact structure in the brain?
Monroe-Kelly doctrine, this hypothesis states the skull is a closed box containing the brain, blood volume, and CSF. An increase in volume in one of these
What is the
components.
percentage?
Ma'am,
What is the
blood
percentage
brain
of
is
brain tissue?
80%, blood volume is 10%, and CSF is 10%, ma'am. An increase in volume in one of these components with an increase in ICP will result in compensatory reduction in the other components to counteract the change. Because brain tissue has limited space to change, compensation typically is accomplished by displacing or shifting the CSF, increasing the absorption of CSF, or decreasing the cerebral blood volume. In the infant, before cranial suture fusion, decompression can occur through an increase in the skull size. The mass effect of occupying lesion can be masked by an increase in skull size. Hence, infants presenting with intracranial hypertension may have a well-advanced pathology.
So what is the relation between the ICP, raised in ICP, and mean arterial pressure and cerebral perfusion?
With the increase in the ICP, with the increase in the ICP, the cerebral perfusion pressure decreases, which is to be maintained throughout the procedure.
Cerebral perfusion pressure, it is the difference between mean arterial pressure at the level of brain and ICP or CVP, whichever is high. CPP is equal to mean arterial pressure minus sum of intracranial pressure plus central venous pressure. Normal range is 70 to 80 mm of mercury. In the neonate, the increase in the intracranial content occurs gradually, such as in congenital hydrocephalus, due to non-closure of suture lines. Any change in the volume of the individual cranial contents can lead to an alteration in the ICP, and this has both pathological and therapeutic implications. So CPP can be maintained by increasing mean arterial pressure, which can be done by giving IV fluids, vasoconstrictors, inotropes. Second, by reducing intracranial pressure, which can be done by hyperventilation, mannitol, sedation, and analgesia. Third one is by reducing central venous pressure by keeping head up position, head in midline, avoiding obstruction of venous drainage of the neck.
So will you avoid the obstruction of venous drainage of the neck during positioning?
We should not tilt the head completely to one side, ma'am. We should just tilt it so that venous congestion does not occur, ma'am.
Okay. If we pose the case for surgery, what are going to order for investigations?
The investigations include all routine blood investigations, hemoglobin, platelet count, total count, blood grouping, viral markers, renal function test, liver function test, serum electrolytes, ultrasound, cranium and abdomen to rule out any organomegaly, chest X-ray, electrocardiogram, 2D echo, CT scan or MRI.
What is the importance of ultrasound of abdomen in this case?
To rule out any organomegaly, any associated syndromes, ma'am.
What is the importance of organomegaly then? What is the procedure you usually will do? VP?
VP shunting procedure, we have shunting the CSF from the brain to the abdominal peritoneum cavity. So we should look after for any adhesions or any peritonitis infection or any mass per abdomen. We have to rule out for that case, ma'am.
Liver enlargement.
Liver enlargement.
It's very good. What are your concerns in this case? Or what do you look for?
We'll look for, as it is a pediatric case group, we should look for prematurity and post-op apnea, associated anomalies like congenital heart diseases, recurrent respiratory tract infections, and associated laryngospasm and bronchospasm, convulsions, vomiting, and dehydration. If at all present, they have to be corrected before posting for surgery. Difficult intubation, hypothermia.
So you are anticipating difficult intubation in this case?
Because of increase in head size.
What are your goals? What are your goals before proceeding for surgery or anesthesia?
The goal of treatment is to reduce ICP and maintain CPP and maintain normothermia, prevent and manage complications, ma'am.
So how will you reduce the ICP before posting the case for surgery?
We should primarily go with the medical management, ma'am, which includes diuretics such as estrazolamide, which reduces the CSF production, furosemide 1 mg per kg body weight to decrease the secretion of CSF at the choroid plexus, and also anticonvulsants, which interfere with impulse transmission of cerebral cortex and prevent seizures. Antibiotics, so culture and sensitivity dependent for shunt infections such as septicemia, meningitis, or is given as prophylactic treatment. And steroids, various forms of steroids have been used to manage hydrocephalus due to associated with conditions such as tubercular meningitis, and intermittent ventricular tapping also done. We can do.
That's how we can reduce the ICP before proceeding for surgery to avoid sudden loss of CSF, which causes. Yes. So what are the surgical techniques?
Surgical treatment is a definitive management, ma'am. External ventricular drain is a short-term solution to the hydrocephalus. The purpose of external ventricular drainage is to divert fluid from the ventricles of the brain and allow for monitoring of intracranial pressures. What is shunt? Shunt is the most common treatment for hydrocephalus and the surgical insertion of drainage system called a shunt. Shunt types are ventriculoperitoneal shunt. A drainage site is from ventricle to the peritoneum cavity, ventriculoatrial shunt, ventricle to right atrium, ventriculopleural shunt, ventricle to pleural cavity, lumboperitoneal shunt, lumbar spine to peritoneal cavity.
Very good. How do you assess the baby then? Or how do you do? What do you look before proceeding for the case in PSC?
We'll see the past medical history, ma'am, and what are the current medications patient is on, like anticonvulsants, estrazolamide, furosemide, and we will evaluate for the congenital neural defects and congenital heart disease and kyphoscoliosis, history of recurrent respiratory tract infections which are secondary to neurological dysfunction, and we will also look for any history of any allergies, and nil by mouth status. Airway assessment could not be assessed in this patient as it is a small child. Signs and symptoms of raised ICP, which causes reduction in the reduced loss of consciousness, reduced level of consciousness, and increased risk of aspiration. If there is any prolonged vomiting and dehydration, fluid correction should be done preoperatively, and we should secure proper IVSS before posting for surgery.
Okay. What are the monitors?
The monitors, the routine monitor includes ASS standard monitors such as the precordial stethoscope, ECG, pulse oximeter, end-tidal carbon dioxide, NIBP, esophageal stethoscope, temperature probe, peripheral nerve stimulator, and special monitors such as precordial Doppler ultrasound and ETCO2 to rule out any venous air embolisms.
So how do you proceed? What is the pre-medication? How do you induce the patient? How do you intubate the patient?
With the anesthetic management, we proceed with the pre-medication. As a general rule, preoperative sedation and narcotic pre-medication should be avoided in all the children suspected for the increase in ICP, as these medications decrease the respiratory drive, which may result in hypercapnia and further increase in ICP. Anxious patients may be pre-medicated with oral or transnasal midazolam. The induction, we start with the induction agents such as propofol 2 to 4 mg per kg body weight or thiopentone 3 to 5 mg per kg body weight. Hypotension should be avoided because of the risk of decreasing cerebral perfusion pressure in the face of raised ICP. IV induction, rapid induction is done to control the airway in emergencies if the patient is not fasted and if no difficulties with the airway have been anticipated. Rapid gaseous induction is preferable at times when prolonged attempts are done to cannulate the patient in a distressed and unwell child. So once anesthetized, secure IV access. We should avoid hypercapnia because it may lead to vasodilatation that increases the ICP in combination with laryngoscopy. Flexometallic tubes are preferable, and we should optimize the venous drainage to increase cerebral perfusion pressure that reduces the venous bleeding. So surgical field can be improved using warm devices, warm blankets. And
so what is the importance of positioning during surgery? So you induce the patient, now positioning.
Child position during the VP Shunt procedure includes should be carried out with patient like supine with head probably turned to the contralateral side. We should just tilt the head to the contralateral side, not extensive tilting of the head should be done. A roll of towel is placed below the shoulders to facilitate tunneling for distal catheters. Better to secure endotracheal tube in the non-dependent corner of the mouth to prevent oral secretions that loses the adhesive tapes used for fastening. The anesthesiologist must try to ensure unobstructed view of the part of the child. Proper padding of pressure points should be done, protection of the eyes from the surgical cleaning solutions, and he should also ready to access the IV lane. He should secure and check ET tubes and breathing circuits before commencement of the surgery. Excessive flexion or extension of the head may cause brainstem compression in patients with Arnold-Chiari malformation syndromes.
So what is the maintenance of the fluid in this case?
Maintenance. Anesthesia can be maintained with a volatile agent and a mixture of oxygen and air. Generally, all volatile agents increases the cerebral blood flow, which may lead to increase in the ICP. But sevoflurane and isoflurane has minimal effects, so we can use sevoflurane in this child case. Nitrous oxide should be avoided because it can contribute to an elevation in ICP. So potential risk of post-op pneumocephalus may develop. The aim is to maintain cerebral perfusion pressure until the raised ICP is released by positioning the VP Shunt. To do this, hypotension should be avoided and minute ventilation controlled to maintain normocardia, to optimize CPP and to avoid increase in ICP. Positive and expiratory pressure PEEP should be minimized to avoid venous congestion in the head, but can be used if there is difficulties in maintaining oxygenation. Mild hypocapnia, PaCO2 of 32 to 35 mmHg following tracheal intubation prevents further elevation of PaCO2. Aggressively decreasing the PaCO2 increases the risk of brain ischemia and is therefore not recommended. The most stimulating parts of the surgery includes initial incision and tunneling under the skin. A short-acting opioid such as fentanyl 1 to 3 mg per kg body weight or remifentanil 1 mg per kg body weight or increasing the depth of anesthesia can be used to attenuate the increase in heart rate and raise in ICP.
So you will supplement some analgesic.
Yes, ma'am.
Just before incision and tunneling of the VP shunt.
Yes.
So importance of temperature in this case, as it is a pediatric case, only 5 kgs weight.
The children are more prone to hypothermia. The shunt surgery requires exposure of the body from head to abdomen. Hence, heat conservation strategies need to be implemented. Causes for hypothermia are large ratio of body surface area to weight, thinness of skin, and limited ability to cope with cold stress, which leads to increased oxygen consumption and metabolic acidosis. Strategies used to prevent hypothermia are increased operating room temperature to 27 degrees centigrade, placing the baby on warming mattress, covered up with blanket, humidification of inspired gases, plastic wrap to water loss, and warming skin disinfectant solutions.
What are the complications?
The complications of shunts include common to all type of shunts: malfunction due to obstruction, disconnection, breakage, migration, and infection. Overdrainage, early overdrainage can cause subdural hematoma. Chronic overdrainage can lead to intermittent shunt obstruction due to slit ventricle symptom. It can also give rise to secondary craniosynostosis and thick skull. Pneumocephalus and seizures are also other complications. The shunt acts as a conduit for extraneural metastasis of certain tumors. Silicone allergy is one another complication.
So when will you extubate? On the table, or you want to ventilate in the postoperative period?
The goals for the emergence include prompt awakening to aid early assessment of the neurological function, hemodynamic stability. Avoid coughing or straining during emergence. If the patient hemodynamically is stable and in order to patient is fully awake, in order to avoid hypercapnia, the patient can be extubated on table. But if the patient's awakening is delayed and no anesthetic cause can be determined, present the neurological issue can be revealed by a CT scan before the tracheal extubation.
So how do you maintain the pain analgesia in the postoperative period? What will you give?
Infiltration
To
of
decrease the
local
post-op pain.
Yes, ma'am. Analgesia is maintained by giving infiltration of local anesthetic bupivacaine 0.25% at incision site as well as at the tunneling site, ma'am. And paracetamol, which is 15 mg per kg, either intravenous or per rectum it is given. High dose of long-acting opioids should be avoided as it causes respiratory depression in these patients. Post-op monitoring post-operate monitoring should be done for the apneic spells in these children.
Okay. Thank you. Madam,
Thank you,
Padma Vishal,
ma'am.
madam. Yeah.
Ma'am, shall I ask one question?
Yeah, I just want to ask one question. As you told that patient is having a difficult airway. So how to overcome that?
So you're keeping all the
Hello.
crash cart.
Yeah.
Ma'am,
Able to hear
with
my
the
voice?
difficult airway, we should keep
Yeah.
all the crash cart ready with emergency drugs and proper sized Miller plates. Also, IGL also we should keep it ready, IGL. And during the positioning, we should place a roll over the shoulder such that the airway comes in a single lane. Such that we will get ready for the difficult intubation. If at all difficult intubation is there, we can proceed with the IGL.
Yeah. And always, because it is a pediatric case, two anesthetists must be there, and one who is very good in the managing the difficult pediatric airway. That is a must. And you can even take the head to the edge of the table, like it is an older technique, and you can facilitate the intubation. Second thing, you have already told everything correctly. Like dehydration should be corrected and electrolyte imbalance should be checked before taking the patient. Second thing, I just want to add that the patient who is having the apneic spells and patient who are having less scores, VCS, sedation should be avoided. A third thing I just want to, you have already told. Third thing I just want to tell that when you are, the VP shunt is placed and there is a sudden reduction of intracranial tension, we should actually maintain the normovolumia and the isovolumia and the isoosmolality. So according to that, we can choose our fluids. Other things you have told, like post-operative analgesia and a small short dose of the fentanyl or remifentanil can be given at the time of tunneling the this thing, because these patients will come for the surgeries, because this shunt failure will be there or there is a blockage of shunt every time. So these babies will come for the repeated surgeries. That should be also kept in mind.
Okay.
Yeah, that is. Yeah, thank you.
Thank you.
How do you counsel the patient, Bhani? Or how you counsel to parents? What will you tell them?
Good evening.
We will tell the mother how to position the child at home, ma'am. We'll keep the child lying flat or with head slightly raised, ma'am. Do not keep the head very high and turn the child's head to the opposite side of surgery, we'll tell them, and handle the head gently. And wound care at home should be maintained, ma'am. Do not apply oil or powder or home remedies, we'll tell the mother, ma'am. Dressing should be clean and dry, and do not touch or press the shunt tube, ma'am. We should tell the mother when to come to hospital, ma'am. When there is redness, when there is swelling, when there is discharge, and when there is bad smell from the wound, and when there is clear water fluid leakage, mother is instructed to bring the child to the hospital. What are the danger signs which we should tell the mother are? Repeated vomiting, excessive sleepiness, and the patient is not waking up, and when there is persistent crying, or when the baby is irritable, when there are episodes of seizures, bulging soft spot, when there is increase in head size, we should tell the mother to come to bring the child to the hospital, because these are the signs of raised blood pressure, brain pressure.
In a walking child, what will you tell them? If the baby is in 2 years or more than 2 years, able to walk.
If there are any gait abnormalities,
yes, immediately she should report to neurosurgeon or physician.
Yes,
Good evening,
Praveen?
Sri Lakshmi madam.
Yeah, sir. Good evening, sir. Prasad.
Very nice presentation.
Can I ask some question? Can I ask some question? What is the name of the shunt commonly? What is the name of the shunt commonly used?
Ventricular peritoneal shunt, sir.
No, name, sir.
Yeah. And who is the name of the scientist who first coined, invented the VP shunt?
Yes, VP Shunt.
Chopra shunt is the commonly used, and Dr.
Okay,
Upadhyaya,
sir.
he is a pediatrician, invented this first. He is an Indian.
Okay. Yes, sir. Thank you.
What are the components of VP shunt, and how do you diagnose proximal obstruction from distal obstruction on the table?
Yeah, tell me,
Sir,
Fani.
shunt
What are the components?
usually consists of three parts, sir. Proximal end is a radio opaque and it is placed into the ventricle, sir. This end has multiple small perforations. Second one is valve, sir, which allows for unidirectional flow. It can adjust various opening pressure, sir. Usually it has a reservoir that allows for checking shunt pressure, sir, and sampling of CSF. And third one is distal end, sir. Distal end is placed in the peritoneum or any absorptive surface, sir, by tracking the tubing, sir. Generally, two types of shunts are available, sir. Pressure regulating shunt and flow regulating shunt, sir. Pressure regulating shunts are usually designed to maintain difference of pressure between the inlet and the outlet, sir. Next to the flow regulating, sir, they allow the flow of CSF once that preset pressure has been reached, sir. The flow regulating shunts designed to allow constant flow of CSF, sir, which simulates the normal flow of CSF, sir. Flow regulating shunts.
The reservoir is usually placed and press the reservoir. If it is collapsed, it means proximal obstruction. If it is distended, it indicates distal.
Okay, sir. Okay, sir. Thank you, sir.
Can I ask one question?
Ma'am.
Yeah.
So there is a distal obstruction. They open the abdomen.
Madhavi madam.
Yes. Can you do the VP shunt surgery with supraglottic airway devices? If yes, why? If not, why? And with spontaneous ventilation. Because it is half an hour to 45. What is there? A neurosurgeon can put VP shunt within 15 minutes. Can we go ahead with supraglottic airway device or not? With spontaneous ventilation.
Supraglottic without spontaneous. Yes, madam, you can do it with a supraglottic device. But the baby should not be in spontaneous.
Why?
So it raises, whenever the patient is spontaneous, stress or coughing or straining will increase the intracranial pressure, which should be avoided.
Only that or something else with spontaneous ventilation.
Yeah.
PGs, please respond.
PGs, postgraduates. I want
please.
you people.
Postgraduates, please respond. Any PG, please respond.
Okay, what is the fluid of choice for hydrocephalus patients?
The fluid of choice is normal saline, ma'am.
Premature 5 kg. You'll go for normal saline. What will happen with normal saline?
Ma'am, it is hyperosmolar. It can attenuate the brain edema. It can decrease the brain edema. If at all the baby is 5 months baby and if she is fasting, more prone to hypoglycemia, then we can start with dextrose infusion, ma'am. But with
What is the
hyperglycemia,
concentration of dextrose in premature hydrocephalus babies? How much of dextrose solution can be added to hydrocephalus babies? What is the concentration? Can I go for 5, 10, 25?
5%.
5%. Check the answer. Yes or no? 10? No. Premature babies, you have to go for only 1 to 2% of dextrose containing solution. Okay, you are only telling that it is isoosmolar to be given.
Yes,
Okay,
ma'am.
in spontaneous ventilation, hydrocephalus, the supraglottic airways, we cannot use because you are telling about embolism, no? Whenever
Yes.
they tunnel, so there is lot of chance of embolism. That's why not to be done. One more thing is supraglottic airway device. If you turn the baby to the left or right, so there will be lot of chances of what happens. So there is no a proper securing the airway.
Securing the
That's
airway.
why there is no role. And the two head and neck surgeries, remember that the supraglottic airway devices in head and neck surgeries is very limited. Okay. Okay. If patient with MMC and hydrocephalus, they come, which surgery should be done first? Which surgery? Why? MMC or hydrocephalus?
Meningomyelocele and
Both are there.
surgery.
Which surgery should be done first?
first
And
we
why?
have to correct the hydrocephalus, ma'am, to reduce the ICPs.
Yes. Yeah. So that MMC may get it reduced.
Yes, ma'am.
Okay.
Okay, ma'am.
Okay.
What is the common complication of EBD?
Infection, sir.
Yes. What happens if you,
Sir?
what happens if you drain the CSF rapidly?
Excessive drainage may lead to herniation of the brainstem, sir.
What are the name? Can you name the herniation? 4 herniations are there.
No, sir.
What is flow metabolism uncoupling? Where it happens?
Somebody has written in the chat box, uncle herniation.
Sir, flow metabolism coupling means it direct relationship between the tissue blood flow and the metabolic activity, sir. Especially in the brain, where cerebral blood flow increases or decreases in proportion to cerebral metabolic rate, sir. More metabolism, more blood flow. Less metabolism, less blood flow, sir.
Can you use inhalation anesthetic more than 1.5 Mac in neurosurgeries?
No, sir. It will lead to increase in the cerebral blood flow. So, cerebral vasodilatation occurs, which may lead to the increase in ICP again, sir. So, inhaled anesthetic should be maintained 0.5 to 1.5 max, sir.
Did you ever heard about polyurethane tubes? What is the advantage in pediatric age group? What is that? Any idea? What are the common tubes we use? Made up of what?
PVC tubes, ma'am, endotracheal
And
tube.
did you ever read about polyurethane? What is that?
Polyurethane tubes, those are flexible polymer tubes, ma'am. Ultra thin cuffs will be compared to the PVC tubes, ma'am. Ultra thin cuffs will be there, ma'am. Very thin cuff wall.
And
Yes.
less irritation.
What is polyurethane? Is thin cuff.
Very thin
So
cuff
it
wall
can be
and
used from the birth. Okay, which is very useful for hydrocephalus meningomyelocele surgeries. So very less volume, 0.2 to 0.5 ml of volume
Low
will
cuff
be enough.
pressures. We can tracheal sealing can be done with the low cuff pressures, ma'am.
Yeah. So polyurethane you should know for any pediatric surgeries. Okay.
Okay, ma'am. Okay, ma'am.
How pediatric airway differs from adult airway? Simple question, basic.
Yes, ma'am. Sir, in pediatric airways, head and occiput are large, sir. Tongue is also large relative to the mouth, sir. Tongue is large tongue. Nasal passages will be narrow, sir, and
Larynx is at C3, C4 level.
larynx will be at a higher position, sir, C3, C4 level.
Epi-
Epiglottis is floppy type of epiglottis, sir. Vocal cords will also be angled, sir. And the narrowest part in the pediatrics are cricoid cartilage, sir.
No, subglottic, pediatric. Narrowest
Okay,
part.
sir. Okay, subglottic.
You have not mentioned one hypothermia. Apart from hypothermia, hypoglycemia is also common in infants.
Yes, sir.
Because their liver storage of glucose is less.
Sir.
Okay. Okay, any more questions? Sir, Dr. Kuchel Babu sir has joined. Sir, Kuchel Babu sir. Kuchel Babu sir.
Praveen sir.
Sir, చెప్పండి.
Praveen sir, can I ask one question to PG students?
Yeah, sure. Yes, sure.
Sir, as you have told, you will use flexometallic tube for the intubation. For the 5 months baby, what size tube you will use?
Sir, according to the formula, age by 4 plus 3.5, we have to calculate that, sir. 5 months baby, we'll go with 2.5 3 size flexometallic tubes, sir.
Is 2.5 flexometallic tube available? What
No,
is the
sir. Three size, sir.
3 size?
3.5.
Okay. So what is the smallest flexometallic cuffed tube available and uncuffed tube available?
Sir, smallest
4.5.
Sir, 4.5, sir.
You told already 3 you will use, no?
Yes.
Now you are telling smallest is 4.5?
2 point.
So in flexometallic tubes, plain tube smallest size available is 3 and cuffed tube available is 5.
Okay, sir.
I thought you are using that flexometallic. You told flexometallic, so I thought you are having that. But most of the centers, that smallest flexometallic tubes we are not having. We are using PVC tubes only.
Okay, sir.
Okay. And one more thing, in your summary, you have given the diagnosis with the anomaly also. But in the history and all, you have not told, no, like how you came to the diagnosis. At least that CT report or MRI report,
Yes,
you should.
on CT scan, we have came to that, sir.
Yeah, but with the history, you cannot tell the CT findings. For
Yes,
that,
sir.
you need to tell the CT. And one more thing, if the same baby is planned for MRI sedation, because you told CT or MRI for the diagnosis. So, if same baby planning for MRI sedation, how will you proceed? 5 months baby with a history of vomitings is planned for MRI sedation.
Sir, so prior to the MRI sedation, we should we should look after the saturation levels of the baby in the MRI room. We should start with an antisyllagic and also Orden cetron, sir. And oxygen supplementation should be done with the help of any nasal prongs. And MRI sedation can be done with and with the propofol or ketamine adjusting doses, sir. Mainly propofol, sir, as this is a case of hydrocephalus, ketamine is avoided. Graded propofol dose, and we should look after the any apneic status of the child, and continuous monitoring should be done by the side of the child, sir.
Yeah, but propofol, how will you assess whether patient is apneic or not?
Propofol, how will you assess the apneic or not? Sir, we will look after the chest rise, sir. Whether there is chest rise or not, we'll look after the chest rise of the babies.
So in most of the centers, we will see same like what you are
Keeping
telling only.
Keeping
Cotton over the abdomen also we can keep, sir.
Yeah, this is our regular practice. What we are doing, we will see the chest rise and all. And sometimes if we are keeping the oxygen mask, you can see whether that fog is coming or not.
Okay.
But same time, like if you are having an higher centers, they will be having the ECG monitoring and NIBP monitoring also.
Okay.
And whenever you are planning for sedation, that is NORA, always keep the things ready. Like if the baby and in the NORA, it will be difficult. See, this patient with the enlarged head size, it will be difficult to intubate in the operating theater itself sometimes. So, and in NORA, it will be even difficult. Okay. And if the surgeon is planning surgery immediately after the MRI, you can intubate the baby and do the procedure. Or sometimes even if you put the LMA like IGEL, and you can do the procedure also.
Okay.
I think if some senior can guide even more for the sedation. Praveen sir?
Sir. We'll have a separate we'll have separate talk in the month of February, sir, regarding that NORA. So any more questions from the examiners, as the time is
some centers have compatible ropes.
Sir, yes, sir.
Saturation.
Sri Lakshmi, ma'am?
Yeah. When is indication for a awake intubation for these patients? Hello?
Sir.
Hello. I'm Dr. Kuchela Babu. What are the indications for awake intubation? Awake intubation for a hydrocephalus patient. When you will go for awake intubation? Without paralyzing, without sedating. Any indication is there?
Sir, actually, patients with hydrocephalus have raised ICP, sir. So, it may lead to any cause hypoxia, hypercarbia, coughing, or straining will be there. So, awake intubation can be done. Awake intubation will further raise the ICP, I think.
No, preoperatively, supposedly, you told me how to prepare the patient. Preoperative preparation, they always try to reduce the ICP by giving a
diuretics or medical management.
Diuretics and everything is done.
Sir.
No. Sometimes it is a very, you cannot intubate, you cannot ventilate. At the time, you cannot put a muscle relaxant. The only option is awake intubation only.
Okay, sir.
We should have every gadgets are okay. Something where we didn't have a fiber optic laryngoscope. Or we are based only to save the patient. We will have already told that LMA, that is IGEL. There it is only risk, but all your teachers are telling we cannot. Patient should not be surgery cannot be done in a spontaneous mode with IGEL. sometimes come with a Piri-Robin syndrome with a hydrocephalus. Can you paralyze the patient?
No,
To
sir.
intubate?
No, sir. Yes. Yes.
And will not be awake intubation, at least not a muscle relaxant, without muscle
Muscle
relaxant.
relaxant.
Without muscle relaxant, I taken the deeper anesthesia, plain and spontaneous only. It can't be awake intubation. It is called a
Spontaneous.
spontaneous without a muscle
Muscle relaxant.
relaxant.
Okay.
You can do deeper planes of anesthesia, and you can try to intubate the patient.
Okay,
Now,
sir.
olden days, we are not used to have all these gadgets of airway gadgets. That's why we could not dare to give a muscle relaxant. It is a dictum. The olden days, you could not give a muscle relaxant for all the, especially up to infants. Up to, we never used to give a muscle relaxant. Only give it under deeper sedation only, we try to intubate the patient. Here, the difficult scenario, it is already hydrocephalus, big hydrocephalus with Peri-Rabin syndrome. You should not be paralyze the patient. Take the deeper side and spontaneously induce with a inhalation agent and intubate it. See how can you intubate? At least issue a laryngoscopy. Can easily can see the larynx and we can at that time can ventilate the patient, can paralyze the patient. Okay.
Okay, sir.
Yeah, that is my opinion. I don't know what is the latest. I think your teachers should tell whether you can do it and spontaneously breathing patient under deeper anesthesia. Can you intubate the patient or paralyze the patient? You cannot intubate, you cannot ventilate scenario. What should the option be at that time? Only front of the neck. Can you do that like that? No, I don't think it is not advisable. You cannot, patient is high risk for a, cannot intubate. Definitely should go only in a deeper sedation, deeper inhalation agents and a spontaneous mode and try to intubate the patient. That is my opinion.
Okay, sir. Thank you, sir.
Yeah, Sri Lakshmi ma'am and Padma ma'am and Vishal ma'am, Madhavi ma'am. If there are no more questions, shall we wind up the session, ma'am?
Yeah, it's
You can.
all the
You can.
questions, I think, be answered by the postgraduates.
Thank you, Sri Lakshmi ma'am, for giving us this opportunity, ma'am.
Thank you, ma'am.
That was a
Thank
nice
you, Madhavi
presentation.
madam.
Thank you, ma'am.
Thank you, Padma Vishal madam.
Thank you, ma'am.
Thank you so much, ma'am. Sri Lakshmi ma'am, Madhavi madam, and Padma madam. And thank you, lovely students also. Nice presentation.
Thank you,
Thank you,
ma'am.
ma'am.
May I now request the Treasurer, Dr. Srikanth, to conclude the session with a vote of thanks.
Good evening, everyone. So it was a wonderful evening with very good 2 academic sessions. First of all, a sincere thanks to our guest speaker, Dr. Madhavi Julakanti, madam. We had opportunity to directly interact in our South Zone conference. Now again, see you talk about the topic of ABG, which is very complicated actually, even though it's basic. You just stuck to the topic of what a resident should know and enlighten it in a beautiful way, which is aptly moderated by senior professors Dr. K.L. Subramaniam sir, Dr. Kallepalli Korunath sir, and Lakshmi Rani madam, whose experience and knowledge has added immense value to the session. And a special congratulations to the 2 postgraduates from Andhra Medical College, Dr. N. Fanikumar and Dr. Y. Sharmila. So has done a wonderful presentation on and facing questions from all the senior members in the ISA Visakhapatnam is not a small thing for them being in a residency program now. So which is aptly moderated by their HOD, Dr. K. Sri Lakshmi madam and Dr. Padma Amar Vishal madam, who is HOD in NRA Medical College, and Dr. Madhavi madam. And all the thank you to all the senior members in ISA who have participated in the discussion and enlightened the postgraduates with your knowledge Dr. Kuchal Babu sir, Raman Prasad sir, Rajan Prasad, and many others who have participated in the discussion. It was a wonderful evening. Hope we continue this academic activities on a regular basis. The sports will continue, and we will have many such wonderful academic evenings together. Thank you so much.
Thank you so much. Good night.
Thank you.
Thank you all.